So in 1995, I brought metformin to the United States single-handedly. At that time, we had insulin and sulfonylureas. So when we brought metformin, that was revolutionary. Ozempic, Mounjaro, they can cause up to 15 to 20% body weight loss. So those are phenomenal drugs. The SGLT2 inhibitor class of drugs, which I invented, those are also fantastic drugs.
Dr. Ralph DeFronzo is a professor in medicine, nephrology, and endocrinology, and he's the world-leading expert in type 2 diabetes. He single-handedly brought metformin to the United States, and he's behind the invention of SGLT2 inhibitor class of medication. Dr. DeFronzo, it's a huge honor to be sitting with you today.
Well, it's my pleasure to be sitting with you today. So I guess it's mutual, goes back and forth.
Thank you very much. My first question to you is, type 2 diabetes was always thought to be a single organ disease, a pancreatic central disease. And you have expanded our understanding when you gave the lecture in 2008 that it's multi-organ disease. Could you talk to us about that?
Yeah, because as you point out, we now recognize that there are multiple pathophysiologic disturbances that lead to type 2 diabetes. When I gave the Young Investigator Award in 1987 at the American Diabetes Association, the Lilly Award, I simply titled it the Triumvirate, 3 problems. We know that there's insulin resistance in the liver. So when you go to sleep at night, your liver overproduces glucose. That's the cause of fasting hyperglycemia. Diabetic gets up in the morning, they have their breakfast, lunch, and dinner. The glucose, the carbohydrate that's in the meal, is going to be taken up and disposed of in the muscle, but the muscle's resistant to insulin, so you get postprandial hyperglycemia. And then there's progressive beta cell failure. So 1987, that was a pretty simple understanding of what caused type 2 diabetes. But when I gave the Banting lecture in 2008, I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So we didn't have just 3 problems to deal with. We had 8 problems to deal with. So we know that the fat cell plays a big problem here in the development of diabetes. Now, initially, the fat cell is your friend. You take in excess calories, you store them in the fat cell, and there they can't hurt you. But if you keep taking in excess calories and the fat cells get too big, they become resistant to insulin and they start to break down the triglycerides, the fat in the fat. They release the fat into the bloodstream, and the elevated FFA cause insulin resistance in the muscle, insulin resistance in the liver, and progressive beta cell failure. We've also come to learn that the gastrointestinal tract is a giant endocrine organ. So you eat a meal and you release 2 incretin hormones, GLP-1 and GIP, and those incretin hormones account for about 70% of the insulin that you release in response to the meal. And what we've learned is that your beta cells are very, very resistant to the GLP-1 and GIP. And we have a treatment for that. These newer drugs like Ozempic and Mounjaro are very effective at increasing insulin secretion. We also know that the alpha cell overproduces glucagon, and those elevated glucagon levels drive hepatic glucose production throughout the sleeping hours. Still, they have 2 more problems to deal with. One is the kidney. And so the diabetic has a high blood sugar, so the kidney filters more glucose. But unfortunately, that glucose does not end up in the urine. The kidney hyper-reabsorbs the glucose. And it does so because of an increase in a particular transporter in the kidney called the SGLT2 transporter. This is a discovery that we made many, many years ago. And then we went on to develop a class of drugs called the SGLT2 inhibitor class of drugs that will block glucose reabsorption in the kidney and just allow the kidney to dump the glucose out in the urine. And this turns out to be a very effective way of treating diabetes. And then lastly, the last organ that plays a role here is the brain. And the brain plays a role in a somewhat different way. So in the brain, there are centers that regulate that tell you how to eat, when to eat, how much to eat. So it turns out that these centers in the brain, the appetite regulating centers, have gone into disarray. And so now, because you're resistant to a number of appetite suppressant hormones, such as GLP-1, amylin, leptin, you overeat. And when you overeat and you become obese, you become very resistant to insulin. And of course, that's the worst thing that can happen to a diabetic. So we have 8 problems to deal with. And it should be obvious if we have 8 problems to deal with, one drug can't take care of 8 problems. So I've been a big advocate of starting combination therapy right from the beginning in our diabetic patients. And with the EDIC study now, which is a big prospective study using combination therapy, the American Diabetes Association has finally recognized that we really need to consider starting treatment in our diabetic patients with multiple agents.
How do we know what is the primary organ or which organ has insulin resistance? And can you have insulin resistance and completely normal blood sugar levels on standard blood test?
Yeah, so that's a really important question. So we did a study many, many years ago where in San Antonio, we looked at families where both mom and dad had type 2 diabetes. And now if children are born into these families, they have a very, very high likelihood, about 70 to 80% chance of developing diabetes. So we said, well, let's look at the children of these 2 parents with type 2 diabetes, and let's see what is it that's wrong physiologically and genetically. And what we showed is that these children, and again, they're very young, were severely resistant to insulin. They were already as insulin resistant as their diabetic parents, but they didn't have diabetes. Why? Because their pancreatic beta cells could read the severity of the insulin resistance, and their beta cells secreted enough insulin to overcome the insulin resistance. So the answer to your question is yes, you can have severe, severe insulin resistance and still have normal glucose tolerance. Now, the problem with this is that we know that insulin resistance and some of the metabolic changes that go with insulin resistance predisposed to cardiovascular disease. So although you may not develop diabetes, your glucose level may not go up, you're still at risk for heart disease. And then, of course, with time, that insulin resistance puts a stress on your pancreatic beta cells. And then as your beta cells start to fail and they don't secrete enough insulin, then you develop diabetes. But for sure, the insulin resistance precedes the beta cell failure.
And with these insulin resistant, would you be able to detect them on glucometer or a CGM, early insulin resistance sign, or not necessarily as well?
No, you can't pick them up because the glucose level is normal. Uh, there are some very, very sophisticated techniques that we've developed, but of course, you're not going to go around and check the normal population using these very complicated techniques. But there are some simple things that you can do. If you wanted, you could just simply measure the fasting insulin concentration. And people who are insulin resistant have very high fasting insulin levels. Another thing you can do is just look at the person. People who are overweight, obese, the great majority of these people are insulin resistant. If you have a family history of type 2 diabetes, mother, father, brother, sister, it's very likely you also have the insulin resistant genes. We know that ladies who during pregnancy develop diabetes, then after their pregnancy, they deliver the baby, they go back to normal glucose tolerance. We know that those people are insulin resistant. We know that women who have polycystic ovarian disease are insulin resistant. So as I said, there are a number of clues that tell us that people are insulin resistant. And if you want, as I said, a simple way is just to measure the fasting insulin. You could do an oral glucose tolerance test, a little bit more complicated. And from the glucose tolerance test, we devise an index that's called the Matsuda index. And that index agrees very, very closely with the gold standard insulin clamp measure that we developed. But again, uh, uh, just screening people with an oral glucose tolerance test takes time. It's about a 2-hour test. People, have to come to the laboratory or the clinical research center. They have to ingest the glucose, and then, every 15 to 30 minutes, you have to measure the glucose and insulin. Although for us in the metabolic unit, of course, this is pretty simple, but this is something that cannot be done routinely in practice.
What is the ideal fasting insulin level?
Now, it turns out that there's a lot of variation in the fasting insulin because different labs use different antibodies to measure the insulin. Now, if you're using what I would say is a very good assay for insulin, the normal fasting insulin should be somewhere between 3 to 4, up to about 8 to 9. So I would say anything, above 10 to 12 using our assay would be abnormal. But I've seen many assays where the fasting insulin in the quote normal range can be as high as 10 to 15. That means that that's not a very sensitive insulin assay. So you really have to know a little bit about the lab and the kind of assay that they're using to measure the insulin concentration. So it's not an easy question to answer unless you really are familiar with the antibody in the laboratory procedure for measuring the insulin.
Mhm. And for these individuals who have risk of type 2 diabetes and their genes, they have parents who have diabetes through multiple father and mother, and uh, can they avoid uh, having type 2 diabetes just through lifestyle and eating very clean and trying to avoid refined carbohydrates, exercising, and being on a prevention program most most of their life?
Yeah, so very good point. In the ideal world, the best treatment to treat the insulin resistance and to prevent diabetes is lifestyle. That means staying trim, okay, staying at ideal body weight. You know how difficult that is. In the United States now, 60% of people are either obese or overweight. So from that standpoint, it looks like we're failing. And then habitual exercise 3 or 4 times a week, 30, 40 minutes, moderate intensity, is also very effective in improving insulin sensitivity and preventing the onset of diabetes. So, and we know that these measures work. We have many, many, many trials. The problem is when the patients are in the studies and they're being monitored and they're eating properly and they're not gaining weight and they're exercising, we can show that you can prevent the development of diabetes and you can correct the insulin resistance. But what happens as soon as they get out of the structured diabetes program, they start to gain weight. They don't continue with the exercise program. And then when that happens, of course, now you see later in life the development of type 2 diabetes. So lifestyle, diet, and exercise, of course, the best things that we can do, but they're also the most difficult things for patients to do. And that's why obesity in all Western countries throughout the world is rising dramatically. And as I said, in the US, it's actually 62% of people are either overweight or obese. So obesity is a big problem, and it's a big problem everywhere in the world. And it's a major, major cause that's driving the epidemic of type 2 diabetes that we're currently experiencing.
Do you believe that insulin resistant causes obesity or obesity causes insulin resistance or both ways?
I think it can go both ways, but the way that it normally goes is that it's the obesity that's causing the insulin resistance. People take in excess calories, and when you take in excess calories, those calories get deposited in the muscle as fat. We call this lipotoxicity. It's a term I coined many, many years ago. Fat in muscle makes your muscle very resistant. Fat in liver makes your liver resistant. And fat in your beta cells, that's even worse because fat in your beta cells impairs insulin secretion. So you can see once you start putting fat in tissues in your body, you're affecting the two big reasons why you develop diabetes. You become insulin resistant, your beta cells don't make enough insulin. So again, it behooves people to maintain, a normal body weight. Probably the most important thing you can do to prevent the development of diabetes.
You have talked about fatty liver. Can someone have insulin resistant in the liver without fatty liver disease? So he would do an ultrasound and it will show clean liver without fatty liver, but he would still have liver insulin resistance.
Yes, that can happen, but of course, the most common cause of fatty liver is just general obesity. People take in too many calories, and as I said, you put fat in all tissues in your body, including the liver. And we also know you put fat in your heart, and this can lead to heart failure. You put fat in your blood vessels, this leads to plaque formation, blockage of the coronary arteries, you have a heart attack. So when you think about obesity, you should not limit it in just thinking the fat's being in one organ, maybe in your tummy, okay? In your tummy, in the subcutaneous fat is pretty benign, but the fat does not just get deposited there. It's in your muscle, in your insulin resistance, in your liver. We call this MASH or MAFLD. It's in your beta cells. It's beta cell failure. It's in your heart. Leads to heart failure. So obesity is a huge problem. And of course, the gastroenterologists are very interested in liver fat. And it is very, very clear that when you put fat in your liver, this is associated with insulin resistance in the liver, and it's also associated with cirrhosis. And now fatty liver is the commonest cause of cirrhosis in the United States. It's surpassed alcohol as a cause of liver failure.
Can you have a fat in the kidney, and why don't they test for other organs like the kidney for fat in the kidney? And would that disturb the cause metabolic dysfunction in the kidney, like causing hypertension and other diseases?
Yeah. So I think fat in the kidney is something that's been markedly overlooked. And several years ago, I wrote a very nice review article in Nature Reviews Nephrology, and I called it the Ominous Octet for diabetic kidney disease. And one of the candidates of the Ominous Octet was fatty kidney disease. And I think this is something that's really not well appreciated by endocrinologists or nephrologists. And if you do a kidney biopsy in people with type 2 diabetes, you can show that there's fat in the glomerular cells, leading to glomerular sclerosis. There's fat in the mesangial cells, leading to mesangial hyperplasia. There's fat in the tubules in the interstitium, leading to inflammation. So all parts of the kidney are affected by an increase in fat in people who are overweight and type 2 diabetes. And therefore, I believe that losing weight is also very important in preventing the development of diabetic kidney disease, or probably it should be better called fatty kidney disease. So I think when you have an obese diabetic with kidney disease, there are two problems. It's the high glucose damaging the kidneys, as well as the high fat in the kidneys that are damaging the kidneys. So we need to lower the glucose, and we also need to get people to lose weight to get the fat out of the kidney.
Can you test these through regular imaging like CT or ultrasound, or only through biopsy you can find out if you have fat in the kidney?
Yes, there are, radiographic technology, MRI, that you can detect the fat in the kidney. And of course, you can also detect it when you do the kidney biopsy. But these are tests that are not routinely done, in the workup and evaluation of our patients. And in fact, one of the things that I think is sometimes underutilized is the kidney biopsy. So there was a very nice study from Columbia some years back, and there were, I think, about 600 people in this study, and they biopsied these people prospectively. And what they found was that in about 1/3 of the patients, they actually had something other than diabetic kidney disease. And one of the things they found was a lot of fat in the kidney in these people, whether they had overt diabetic nephropathy or not. So I think that fatty kidney disease is something that is certainly overlooked. And as I said, There are ways you can, with MRI, imaging technology, you can detect the fat in the kidney. It's something that we're particularly interested in, but I would say it's not something that's focused on by physicians, including nephrologists.
Can you reverse this fat in the kidney through lifestyle adjustment, through cutting refined carbohydrates, or fasting, or exercising, or pharmacological therapy?
Yeah. So the kidney is no different from any other organ in the body. If you lose weight, as I said, the best thing is stay lean, okay? Lean and mean. That's probably a good, good thing to remember. But yes, absolutely. If you lose weight, you move the fat out of the kidney, you move it out of the liver, you move it out of the muscle, the skeletal muscle, you move it out of the heart, you'll move it out of your pancreatic beta cells. So you improve insulin sensitivity. And equally importantly, when you move the fat out of the beta cells, you improve beta cell function.
Is there anything can improve the eight pathophysiological defect that you have introduced?
If we're talking about the Ominous Octet for diabetes, okay, and remember I said there's a different Ominous Octet for the kidney. Yeah, we have great drugs for treating people with diabetes. So in 1995, I brought metformin to the United States single-handedly. At that time, we had insulin and sulfonylureas. So our treatment of diabetic patients was very limited. So when we brought metformin, that was revolutionary. But, compared to today, that was pretty archaic. So today we have phenomenal drugs. The GLP-1, glucagon-like peptide 1 class of drugs are outstanding drugs. They have a huge, huge effect to improve your beta cell function, which is a big problem in diabetics. And they're very, very good at making you lose weight. So the newer drugs, Ozempic, Mounjaro, they can cause up to 15 to 20% body weight loss. So those are phenomenal drugs. The SGLT2 inhibitor class of drugs, which I invented, those are also fantastic drugs because they not only lower your glucose, your A1C, but they provide kidney protection and they provide cardiovascular protection. The GLP-1 receptor agonist drugs as well also provide kidney protection and cardiovascular protection. The third drug I use in my practice is Pioglitazone. It's the only true insulin sensitizing drug. A lot of mixed feelings because of the misconceptions about Pioglitazone, but in my opinion, it's an excellent drug. It is the only true insulin sensitizing drug. So we treat our diabetic patients with triple combination therapy right from the beginning, and that's a GLP-1 receptor agonist, and it's usually the one that's on the insurance plan that the patient can pay for because those drugs are expensive, an SGLT2 inhibitor, and also Pioglitazone. Metformin is a good drug, but actually now it's number 4 on my list of good drugs. But I'm happy if docs use metformin. It's a very good drug. But you're going to have to use these drugs in combination. Now, at the level of the kidney, we need to be thinking about what are the drugs that work on the kidney. And it's a little bit of a different combination here. So we've known for many, many decades that ACEs and ARBs are critical for protecting kidneys. They're also good for protecting you against atherosclerotic cardiovascular complications. So ACEs and ARBs should be used. As I said, SGLT2 inhibitor studies that we and others have done are very, very protective of your kidney. So diabetic patients with kidney disease should also be on an SGLT2 inhibitor. There's a newer class of drugs called non-mineralocorticoid receptor antagonist. Finerenone is one of the drugs in this class. It's a very, very good drug. Patients should also ideally be on this drug. And then more recently, we have a very nice study. It's called the FLOW study, showing that at least one GLP-1 receptor agonist, Ozempic, is very good for protecting kidney disease. So we have 4 good drugs that can help people in terms of preventing diabetic kidney disease. And we need to use these drugs in combination and start them early if we want to slow the progression of diabetic kidney disease. So we really are much better off than in 1995 when we had insulin and sulfonylureas. I mean, when you think back, that was pretty barbaric. And metformin was revolutionary, but now we truly have a revolution with all these newer drugs and many more new ones to come.
And what's your most preferred agent in CGLT inhibitor? Do you have one?
Uh, to me, once you block the SGLT2 transporter, you're going to get the same effect with all of these drugs. So I think the best drug is the one that's on the patient's insurance that he hasn't or she doesn't have to pay for. The two most popular in the U.S. are dapagliflozin and empagliflozin, and quite frankly, I don't even make the choice. So I just write SGLT2 inhibitor, and when the patient signs out with the ward clerk, she looks at the insurance that the patient has, and whichever drug is on the patient's insurance plan, that's the one that they print out the prescription for. So these are great drugs. I think they're virtually identical, interchangeable. The key is use one of them, okay? I don't care which one you use, just use one of them.
Is there any of them that are superior in lowering blood pressure or better for blood pressure lowering than the other?
Yes, the SGLT2 inhibitors, the S is for sodium, the GL is for glucose, T is transporter. So you block glucose and sodium reabsorption. So you go into a little bit negative sodium balance, as we've shown. And when you put people into negative salt and water balance, that's good for lowering your blood pressure. So these drugs, the SGLT2 inhibitor drugs, have modest blood pressure lowering. But if you really have hypertensive diabetic patients, they're usually going to require 2 or 3 drugs. One of them is going to be a diuretic. And we have a lot of good drugs for lowering blood pressure. We have, as I said, the ACEs and the ARBs. We have calcium channel blockers, etc. So we do have good medications. But again, treating blood pressure can be difficult in our diabetic patients and usually requires 2, 3, sometimes more drugs to get the blood pressure controlled.
Can I ask 1 or 2 questions about hypertension?
Sure.
Hypertension is a very complicated disease, too many organs involved, white coat syndrome, and there is white
Yeah.
coat syndrome also from day to day. Does that spike in blood pressure causes endothelial damage or organ damage?
And the answer to that is yes. Okay. So any elevation in the blood pressure is going to be deleterious. Okay. And people respond differently to stress. You know, every day of my life, I'm under incredible stress. And if that drove my blood pressure up, I probably would have died a long time ago. But my blood pressure actually is it's like textbook perfect, 120 over 80. And I assure you that my day is very stressful. And then there are other people who even modest stress can really elevate their blood pressure. And that on a long-term basis will have a negative impact. And as you said, blood pressure and hypertension is very complicated. There are many factors that are involved. And we now have good instruments for doing home blood pressure monitoring. So we also know that there's a dipping of blood pressure at night, and this can be lost. So there are subtle changes in blood pressure that can predispose to atherosclerotic cardiovascular disease. So controlling blood pressure is extremely, extremely important, particularly in diabetic patients. Hypertension is a huge problem for diabetic patients in terms of progression of cardiovascular disease and progression of kidney disease. So it is very important that we really keep the blood pressure as close to normal as possible, meaning 120 to 130 over 80. That can be difficult. It can be done, however, because we do have a large number of antihypertensive drugs that can be used in combination. And if you do that, you can effectively get the blood pressure controlled in the majority of patients. One of the things that tends to get forgotten is diuretics. It's very difficult to control blood pressure unless you put people into a little bit of negative salt and water balance. So these kind of people with, a mild diuretic, maybe with a calcium channel blocker, can do really quite well. The key thing is to monitor the blood pressure in whatever you use to lower the blood pressure. You need to see, is it working? And so I recommend home blood pressure monitoring, particularly when you're starting medications in patients, so you can follow whether you're getting the kind of response you're not. Yeah, you can check your blood pressure 2 or 3 times during the day. That would be sort of second choice. But if you are monitoring it throughout the course of the day, you get a much better picture of what's going on. And you also learn what are the factors in life that stress you. And so if there are certain environments or situations which you see are particularly stressful, and you can see they jack your blood pressure up, then I think it's important to try to avoid those stressful situations. Although sometimes in the jobs that we have, it's not so easy to avoid these kind of stressful situations.
Too many people have salt sensitivity, and that also causes high blood pressure. Should these people limit their salt completely, and that will improve the kidney function and blood pressure?
Yeah, so it's easy to tell people to cut salt out of their diet, but salt is everywhere in the diet, so it's not so easy to do. But yes, having the patient meet with the dietitian in reviewing, because sometimes patients are taking foods that have a lot of salt in it, and they don't know it. So to the extent that you can cut down on dietary salt, that's important. But as I mentioned just a few moments ago, people tend to forget diuretics. And it's difficult really to control blood pressure unless you put people into a little bit of negative sodium balance. And that's best done with a diuretic. So in the treatment of hypertension, I think it's very beneficial to have a diuretic in combination with what other antihypertensive drug you happen to like.
What blood sugar movement or pattern would indicate early insulin resistance, either on a CGM or on a glucometer, that would show way before you see it on a fasting blood sugar or a A1C?
Yeah, the glucose really doesn't tell you anything about insulin resistance. So that's not going to be very helpful. As I pointed out to you when we started this discussion a little while ago, you can have a perfectly normal glucose and be very, very insulin resistant. There's nothing about the glucose that's going to give you a clue. Now, people have used an index. It's called HOMA-IR, uh, HOMA insulin resistance, and this is basically a product of the insulin in the glucose. Okay, so as I said, the earliest sign that you're insulin resistant is your insulin level is going to go up. Now, if your glucose, and that should control the glucose. So if you have a person and the insulin level is up and the glucose level is up, that means you're more insulin resistant. Okay. Uh, that, as I said, it's called HOMA-IR. Uh, so some people like to use the HOMA-IR index, uh, but as I said, uh, the first thing that's going to be a clue is that the insulin level is going up. And the next most, I guess, used tool would be the HOMA-IR index. And then I guess the next simplest tool would be to do the oral glucose tolerance test and get the Matsuda index. And then the most sophisticated state-of-the-art method is our technique that we developed. It's called the insulin clamp technique, where we're going to infuse insulin and then with radio-labeled glucose, measure precisely how much glucose is taken up by all the tissues in the body. That's just a research tool. That's nothing that you would use in clinical practices. And even the OGTT is really used in clinical practice.
Do you think glucometer or CGMs are useful to monitor for non-diabetic who's trying to prevent diabetes?
This is maybe a kind of controversial topic, but in my opinion, not really. If you have normal glucose tolerance, okay, and a normal A1C, there's no need to be looking at your glucose levels throughout the course of the day. They're probably going to give you is psychologically a problem. Now, if you're a diabetic, now this is a totally different story, of course, because if you're a diabetic, you definitely want to know what foods that you eat are really increasing your blood sugar level. The only way you can know that is if you're doing CGM. So if you are a diabetic, then we know if you look at sort of what all the major diabetes organizations say, if you're a type 1, you for sure should be doing continuous glucose monitoring. If you're a type 2 on insulin, you should be doing continuous glucose monitoring, okay? If you're a type 2 on oral agents or just diet control, in my opinion, continuous glucose monitoring can be very helpful when you're changing the medication dose. Uh, so for the 2 weeks after you start a new medicine, you want to see what's happening. And then I think it's also can be useful for patients periodically to see they eat different foods. What are the foods that really increase the glucose? Less indicated in type 2 patients who are not on insulin, but indicated, in my opinion, in type 2s in whom you're changing their medications or in whom you want to see what foods are doing in terms of the rise in blood glucose. So, in say pre-diabetes or normal glucose tolerant individuals, I don't really see a big indication for continuous glucose monitoring in such individuals.
And what is an ideal response to uh, a full meal that contains carbohydrate and protein and fiber? What is an ideal blood sugar response at 30 minutes or 1 hour or 2 hours?
Yeah. Well, there is no ideal response because that depends on what you just ate. Uh, so in the real world, most people their blood sugar really goes above 150 to 160 if you have normal glucose tolerance, and then 2 hours later it's back to normal, 90 or whatever your baseline is. Okay, but of course, if you take a simple sugar just as pure glucose, like I did an oral glucose tolerance test, your blood glucose level is going to go much higher. On the other hand, if I give you a pure starch, your blood glucose probably won't go above 120. So there is no real answer to your question because you have to relate it to what type of carbohydrate the individual took in.
Is there a spike or a level where you start to get endothelial damage or kidney damage or organ damage?
Normal people, I would say, really no. In diabetics, uh, we have criteria uh, that says if you're 2 hour glucose during the OGTT, and you can extrapolate this to meal is greater than 200, you have diabetes. If it's greater than 140, you have prediabetes. And we know that people with prediabetes are at increased risk for cardiovascular disease. So you would not want your 2 hour glucose to be above 140. My guess is that there would also be a relationship between a 2 hour less than 140 and atherosclerotic cardiovascular complications, but there it would be markedly less than if your glucose was, of course, above 140, and in that person, even markedly less than if your 2 hour glucose is above 200. So these things tend to be linearly related. So the lower, the better.
If someone gets some form of beta cell dysfunction, either pre-diabetic or diabetic, is that reversible or once the cells get damaged is irreversible?
Oh, no, no. Of course, it depends on how long you've had your diabetes for and how long you've been poorly controlled. But the medications we have now are very good at restoring beta cell function. So we did a very large study. It's called the QATAR, QATAR, after QATAR study. And we took people who were very poorly controlled. These were people who had A1Cs 10 or above. They had their disease for 10 to 15 years. And the standard sort of thought before this study was that these people have irreversible beta cell damage. They have to go on insulin therapy. And that's what we normally did to treat these people. But in fact, what we did is half the people we treated with insulin, and the other half people we treated with exenatide, an old-time GLP-1 receptor agonist, and pioglitazone. 3 years later, they had an A1C of 6.1, which is pretty close to normal, and markedly improvement in beta cell function.
Mhm.
So, of course, the longer you have your disease, in the the longer it takes for you to treat it, if you start to lose beta cells, and the more difficult it is going to get them to come back. But as we showed, even people with advanced beta cell dysfunction, oftentimes you can restore a large part of that beta cell function and get their glucose homeostasis back pretty close to normal.
And one of the excellent medication for diabetes is Pioglitazone, and you have cleared so much of the misconception about it with the heart and with the edema and how the weight gain is physiologically beneficial.
Yeah.
Yes, I want to ask you about some other misconception. One of the concerns about it that it increases the risk of bone fracture or osteoporosis, and other one is increase the risk of bladder cancer. Are these also misconception?
So the issue of bladder cancer is a misconception. Uh, so the Food and Drug Administration asked Takeda to do a very large prospective study. It was done in California at Kaiser Permanente Northwest, and they looked at a large number of diabetic patients treated with pioglitazone and compared them to a large number of diabetic patients treated with a non-pioglitazone drug. And the hazard ratio for bladder cancer was basically 1, meaning there was no increased incidence of bladder cancer. Now, the bone story is a different story. In postmenopausal women, there is an increased incidence of osteopenia, osteoporosis, and fractures relating to fall. You don't see this in premenopausal women, and you don't see it in men. So in all of my patients, uh, uh, who I'm treating who are diabetic, who are postmenopausal women, we're getting a bone mineral density scan on them anyway. That's just part of normal treatment. And if they have osteopenia, I don't use pioglitazone in that population. That would be the one side effect in that population of postmenopausal women that I would be concerned about using pioglitazone in.
GLP agonists are excellent for weight loss, like Mounjaro and Ozempic. Once they improve their A1C and they lose weight, do you try to get them off it, or does it just continue with the medication?
Yeah. So as you pointed out, these are phenomenal drugs and they cause really powerful weight loss.
Mm.
But the downside is once you stop the drug, you're going to regain the weight. So 80% of the weight is regained within a year. So there are 10 or 15 or percent of people who, after they lose the weight, are able to maintain the weight loss. So that's good. But the fact is, the other 80 or 85% of the people are going to regain the weight. Uh, so uh, what it's telling us is there are clearly disturbances in the appetite regulation center in the brain, and we haven't corrected the problem. We've overwhelmed the problem. We temporarily normalized it, but once we stop the drug, the problem is still there. So they start to eat and take in excess calories, and they regain the weight. Either you stay on the drug if you want to stay lean, because if you stop the drug, you are going to regain the weight. This is a challenge that we haven't solved yet. I mean, we're all looking at some of the newer drugs to see if they will do a little bit better. But right now, I think it's pretty clear that you are going to regain the great majority of the weight within a year if you stop the drugs. The other issue with these drugs is, of course, expensive. In the United States, Mounjaro and Ozempic are about $1,000 a month. And for most of my patients, that's a problem, quite frankly. Cost is clearly an issue. And another, the other factors are the GI side effects. I have to say, once the person has been on the drug for a month, GI side effects are really not the major issue that people stop the drug. Okay. When you first start the drug, yes, maybe they can't tolerate it in 5 or 10% of the people. But once they get on the drug, recurrent the GI side effects tend to go away. The other big problem, many of my patients tell me that, Dr. D, I'm not happy with my life. I said, what do you mean? Yeah, I used to enjoy eating and drinking wine, and now I don't enjoy eating anymore. I don't drink wine anymore, and I'd rather be a little bit fat. So I'm going to stop the drug and go back to my old habits. And that's the commonest reason why most of my patients stop the drug after they've been on it for 6, 7, 8 months.
Any concern or contraindication with the thyroid
No,
disease or
no,
thyroid?
no, this fairy tale,
Y-
uh, if you're a rat, you're in trouble. So there are C cells in the thyroid that the GLP-1 can bind to, and this can cause hyperplasia of the C cells in medullary thyroid cancer. We don't have C cells on our thyroid, so uh, even though there's a strong warning, uh, if you have someone with a genetic cause of medullary thyroid cancer, of course, you should not be using the drug in these people. But this is a very rare disease. The problem is thyroid cancer is not that uncommon. So papillary and follicular thyroid cancer. And so you need to be careful when you talk to patients. You need to ask them if they had a history of thyroid cancer, because what will happen is that the you prescribe the drug, they go home and then they go online and they read and they say, "Oh, I got thyroid cancer. I shouldn't be taking this drug." But they have follicular, they don't a different type of cancer other than medullary thyroid cancer. So it's important to review the thyroid history with the patient when you're prescribing these drugs. But if you have a family history of medullary thyroid cancer, you absolutely should not be on these drugs.
I have another question about pioglitazone. They take away the fat from other organ and put it as a subcutaneous fat. Do they also take the fat from the arteries, the fat that builds up in the arteries? Does it take away any of that fat and puts it as a subcutaneous fat?
It does, and there's a very nice study. This was done by Dr. Stephen Nissen. And so what he did is that before starting the pioglitazone, he did a cardiac catheterization, and you can pass a catheter down into the artery, and then with ultrasound, as you pull it back, you can take a picture of the plaque in the artery. You just bounce the sound waves off the artery. And then he treated the people with pioglitazone for a year and a half and showed significant regression of the fat and the plaques. So we have really good data indicating that pioglitazone does prevent the atherogenic process and removes the fat from the arteries, just as it removes it from the liver. In my opinion, it's the best drug for getting fat out of your liver. I know that the GI people don't use it, but the fact is, the original study was done by Dr. Ken Kuzi and I and published in the New England Journal of Medicine many years ago. And I believe still that pioglitazone is as good as any modality we have for treating fatty liver disease. It gets fat out of your beta cells, gets fat out of your muscle, it gets fat out of your myocardium, it removes the layer of fat around your heart that's interfering with how the heart is contracting. Uh, so it generalizes mobilizing the fat into the subcutaneous area where it can't hurt you.
And I heard you before say that it also improves the only medication that improves mitochondrial function.
It does have a major effect to improve mitochondrial function. We've been very interested in studying the molecular etiology. I don't want to bore people, but it does affect the mitochondrial protein carrier and has direct effects on the mitochondria. Some of the effects are mediated through PPAR gamma. Some of the effects are mediated through the mitochondrial pyruvate carrier. Little probably too technical for your audience, but yes, it improves mitochondrial function.
Is it the only medication that is a insulin sensitizer?
In my opinion, it's the only true direct insulin sensitizer. If I put you on Mounjaro or Ozempic and you lose weight and I get fat out of the muscle, that will improve insulin sensitivity. But it's not a direct effect of the GLP-1 receptor agonist. It's an indirect effect secondary to getting the fat out of the muscle.
What is the best diet in reducing the risk or reversing type 2 diabetes or pre-diabetes?
The best diet is the one that keeps you lean, okay? So the American Diabetes Association now does not recommend any specific diet, okay? So in my opinion, it's not good to force a diet on a patient. What you need to do is, and first of all, doctors don't have enough time to talk to patients about dietary management. They're usually too busy seeing the patients. So the dietitian is very, very important here. But the dietitian needs to meet with the patient and see what the patient's preferences are. And the dietitian needs to work out a diet that the patient can comply with. And of course, the hallmark of diet therapy is trying to get people to lose weight. Uh, and in general, the more excessive the diet, if they're going to put you on a 500 calorie diet, the faster you lose the weight, but the faster you regain the weight. People don't stay on these very restricted diets. So we generally say moderate caloric restriction, about 500 calories, okay? Uh, with a diet that the patient will adhere to. And then the other big thing I would say is you need to make sure that it is low in cholesterol. Because high cholesterol diet is going to be a disaster. You can do many other things with the diet, but in my opinion, the two most important things are try to get people to lose a little bit of weight and make sure that the diet is low in cholesterol.
Does exercise improve insulin resistance in the muscle?
Oh, yes. We actually, the very first exercise studies were done by us some 50 years ago. Uh, but one single bout of exercise will improve insulin sensitivity, and it will last for many hours, but usually after the single bout of exercise, but then 24 hours later, it's gone. So you have to do repetitive exercise. You got to be doing it daily, and if you will do so on a long-term basis, you can improve insulin sensitivity. Now, the bad side of the story is, let's say you stop for a week or 2 weeks, you
Everything go
lose,
back.
yeah, it goes back. Yeah. So it's something that you have to do on a regular daily basis.
Is there a certain type of exercise that shows better results, whether cardio or strengthening or isometric?
No, we recommend a combination of aerobic and anaerobic. Resistance training is very good at improving insulin sensitivity, but it's not necessarily so good for your heart. Walking, jogging, that kind of exercise is good for your heart. It also improves insulin sensitivity modestly. So we recommend a combination of anaerobic and aerobic exercise.
Walking after a meal improves insulin sensitivity?
Uh, yeah, but again, uh, walking is not very powerful. Okay. So whatever improvement you're going to get, I would say is really quite small. Uh, you really need to be working at 40 to 50% of your VO2 max, and you need to be doing it for 30 to 40 minutes. That's not walking, quite frankly. Do I recommend walking after a meal? Yes, you are going to burn up some calories. Uh, but people have misconceptions about walking. So if you can walk a mile in 20 minutes, which most patients should be able to do, you will burn up about 80 to 100 calories. So that's not a lot of calories. You know, you go home and you have a quarter of a piece of pie, and that's 300 calories. So, yes, walking after eating or any walking at all is good, uh, but it's not going to burn up an enormous number of calories. But even in the nurses' health study, they showed that even walking once a week decreased the likelihood of having a cardiovascular event later in life. So any exercise is better than no exercise, and more exercise is better than modest exercise.
Mhm. Does intermittent fasting improves insulin sensitivity?
No, intermittent fasting is a fairy tale, in my opinion. So, look, if you skip a meal and you take in fewer calories, you're going to lose weight. Okay, that's intermittent fasting. There's nothing magical about intermittent fasting. It means you just didn't take a meal. And if you didn't take a meal, that's fewer calories. So if you're going to lose weight, there's an improvement in insulin sensitivity. That's not magical. That's exactly what you'd expect if you took in fewer calories. For instance, I eat once a meal. I've been doing it since age 18. Not because of intermittent fasting. I started this, 50 years ago. It just had to do with my lifestyle. So I do it all the time, uh, uh, but not because I think it has any magical impact. And Sam Klein, who's one of the big kingpins in the obesity field, he's written a very nice review on all these intermittent fasting studies. And his conclusion is it really doesn't have any benefit on glucose metabolism or insulin sensitivity whatsoever. And I would agree with Sam.
Is it healthier for insulin sensitivity to eat multiple small meals a day throughout the day, or just one meal that has more bigger impact?
Yeah. In my opinion, calories are calories are calories. It doesn't make any difference how you take them in. You take in too many calories, you're going to get fat. You take in fewer calories, you're going to lose weight. So, taking in multiple small meals usually turns out to be a disaster for diabetic patients because they don't take in multiple small meals. They take in multiple meals, but they're not small. In general, I don't recommend, or our dietitians don't recommend multiple small meals. It's better for the patient to do what is normal for most people who take 2 or 3 meals and maybe a snack sometime. But again, if you look at the most recent ADA recommendations, what they tell you is that the best diet is the one that works for the patient, and that they're not recommending any specific diet. It's whatever diet is best in maintaining the patient's body weight.
Adding fiber to the diet can help in mitigating the blood sugar response.
Yeah, that's well known that a high fiber diet will decrease the response and the rise in glucose after a meal. It also is good because it makes the patient feel full and they eat less. So high fiber diet in general is recommended. Yes.
Dr. DeFronzo, thank you very much for this informational. I have learned a lot, and I'm sure the audience have learned a lot, and it has been a huge honor and pleasure to speak to you. If people, would you like to add anything that we have not talked about in this
No,
interview?
No, I would like to thank you for the opportunity to, share the information. Hopefully people listening in will, benefit by it. It will help to improve their lives. So I'm glad I was able to do this with you, and hopefully the patients will, get some information from it. Will help them in their life, particularly the diabetics, in terms of helping to control, their blood sugar and their cardiovascular concerns.
Well, thank you very much. I'm sure it will help a lot, and thank you for all of the great work you do.
Appreciate it. Thank
Thank you.
you.
Thank you.
Yep. Bye-bye.
Bye-bye.